Hi, my name is Peter. I'm an emergency physician resident from Denmark, currently working in Stockholm. Today I want to talk to you about a really important topic for emergency physicians in particular, but in general in medicine, and everyone who's interested in education or want to be an educator in emergency medicine or in medicine in general probably needs to know about these topics and how to implement the pearls of this area of science so that you can optimize your learning experience and make learners expert in the best case scenario. Before we head into this lecture, I would just like to say I am no expert. At most, I am an advanced beginner in this area. It's a hobby of mine to educate people about these things, and I've been writing blogs and podcasts and videos about this topic for a couple of years, and I'm an instructor in the emergency medicine core competence course where we adapt some of these theories and hypotheses and implement them into an educational experience for our learners. So I do have some experience with this, but as we will see through this lecture, that doesn't mean that I'm an expert. So what I want to say with this disclaimer is that please look through the literature yourself, listen to the true experts in this field, which we will go through so you know them, and take this as an overview. And if I make mistakes and say anything that is not correct, then please comment in the section below, or write me at my email address. Before heading into the lecture, I just want to, as always, show you some of the main sources if you want to go further in this topic. The middle here, Graeber, Gigerenzer, Gary Klein, Daniel Kahnemann, a lot of you might know him, Norman, and Elstein. They are all some, not all, but some of the most important figures in this area of decision-making science and expertise science. And if you want to like a deep dive into this area, I would suggest reading Daniel Kahnemann or Gary Klein, and then going on from there. Elstein is one of the pioneers in this area as well, especially in medicine, in medical decision making, and he's done he's one of the grand old men in this area. If you particularly want to know something about medical decision making, and maybe specifically, even more specifically, emergency medicine decision making, then you should check out Patrick Croskerry. He's kind of, in my words, he's the best of both the deep science, but also the application of the deep science, and telling it in a way that emergency physicians can understand and maybe even apply. Patrick Croskerry himself is an emergency physician. He's a professor in emergency medicine, and he's also, I believe, a cognitive psychologist. He's written a bunch of articles, and most of them are on the same topic. So some of them are more general and some of them more specific. But if you wanted like a quick overview of some of them of the main area, then this article, Cognitive Deep Biasing Part 1 and 2, is one of the better ones, I think. But there are also a lot of others. So if you find one article in PubMed, then usually you will find all of the others or related articles from him, and you can go on from there. He's also written 2 books on this topic. He's written several other books, but specifically on the decision-making topic. Then he wrote a book in 2017, I believe, called Diagnosis Interpreting the Shadow, along with some other authors, which delves into more of the deeper science of this area. So it's a bit nerdy, but it's like I wouldn't say the Bible, but it's really a thorough reference for this area, for this topic. Then you have a more pragmatic, a more clinical focused book that came out last year in 2021. 2020, I believe. It's called The Cognitive Autopsy. And it's a great book that I think Patrick Croskerry has been using for a long time. Actually, it's like a case. It's like a collection of cases that illustrates a lot of these cognitive biases that we are going to talk about, and it just goes through a lot of the theory, but also like how to apply some of the stuff and how to actually fix some of the inherent problems of our thinking. Highly recommended. And if you want to buy any book in this area, I would suggest beginning with The Cognitive Autopsy. And then, of course, there's lots of lectures by Dr. Croskerry on the internet. It's like on YouTube, but he also did a SMAC talk, and a lot of them says kind of the same thing, kind of like his articles. There are nuances to the different lectures, but in general, it's the same concept that he's talking about. So you can almost pick any of them, and you will see him go through like the bread and butter of this topic. Then on the far right here, I have a couple of references that I believe are more digestible for the average emergency physician or average doctor who wants to get into this topic. They don't necessarily specifically talk about this specific topic about decision making, but they use decision making and they use the theories to build some of their arguments, and it's a great way to see how you can apply these things and why this is so important of an area for us to know about. Society of Improving Diagnostic in Medicine is a society that Patrick Croskerry, I believe, is also part of. And one of the members, Catherine Lucy, has done some YouTube videos on decision making, like an entire series that delves into a lot of the what you would call system 2 analysis, probabilistic analysis, and some of the background. So if you want to delve into that kind of thing, then you should check that out. Society of Improving Diagnostics in Medicine have a homepage. And they have some YouTube videos talking about how to assess your learners. It's like a 5-part series, and I think that's some of the best material there is on their page. But they have a lot of other articles and they produce materials, so check that site out. It's really great. The sum of all of this system 2 kind of deep thinking can be read in this great article by Judith Bowen, Educational Strategies paper, which came out a couple of years ago, but it's still relevant, and it delves into all of these topics that you might need to know about. Then Rahul Padwari, he does great videos. He's an emergency physician who does these great videos as well on topics like decision making and probabilistic thinking. Sidney Dekker is I believe, patient safety or in general error guy who, sorry, I don't know the exact title, but he's written a lot of books on patient safety and failure culture and how we can better learn from failures as a system and as an individual. Written about hindsight bias. All of his books are on YouTube, where he goes through them in lectures. So if you don't want to read his books, then there are some free lecture series that are, I believe they're under an hour each of them, so you can like go through his books in under an hour, and I recommend that. They're great, and he's a really empathic person and a great teacher. Then you have Simon Carley, one of my favorite emergency physician teachers, who's known for his smack talks about probabilistic thinking, and he has his Sankt block. And he's even written an ebook on this topic as well, probabilistic thinking. For this specific area of decision making in medicine, how we can learn from decision making and cognitive biases, you can check out his "Can We Teach Clinical Judgment" YouTube video. Eric Driver and the EMCC course, I'm biased, but I believe he's in Scandinavia one of the big drivers, and maybe in Europe in general, one of the big drivers of this this kind of probabilistic thinking, this kind of metacognition, and it's like increasing the level of emergency medicine substantially, both through his work in USEM, but also through his work with EMCC. And if you haven't taken the course, then I highly suggest that you take the course, because this is where we talk about these things that we're going to talk about here, and we apply it to normal everyday cases. Okay, and then you have EM Cases, the Canadian foam resource, who has done a couple of episodes on this topic as well. You have Martin Bromley's YouTube videos and podcasts where he goes through these topics as well. And you have there's a book by Scott Weingart called Emergency Medicine Decision Making. Scott Weingart talks a lot about this kind of this topic about decision making and cognitive biases, especially as it relates to system one thinking and expertise, where Gary Klein and Anders Ericsson are some of his guests that are worth checking out in his podcast. If you want a quick overview of the entire topic here, then you should check out Kofidis, Unraveling the Polyphony in Clinical Reasoning, Research in Medical Education, where they go through the entire thing, the entire research area, especially like the middle block here. Not as much clinically, but more like how has medical decision making developed through this kind of science. And then Kahnemann and Klein's Conditions for Intuitive Expertise of Failure to Disagree is like a classical paper on the two main schools of thought in this area, and how they agree on certain things and may disagree on other things. Okay, let's head on. And this was the Diagnosis Interpreting the Shadow book, and this was the Cognitive Bias book. I just want to remind you, I've done videos as well on this topic, probabilistic thinking and headache, and in a Danish video called Decision Making in Emergency Medicine. I haven't gotten around to making it English yet, but I might someday. Okay, so here's what I want to go through today. First of all, why is decision making and cognitive biases important? Why is this an important topic? Next, we'll go through some of the hypotheses and then theories and some cognitive biases, and also what makes an expert an expert. And in the end, I want to try to come around and tell you what my through reading this literature and being in this area as a hobbyist, what I think the literature suggests that we should do to mitigate some of these things and become better clinicians. Okay, first of all, why is this important? So the importance of this area can be summarized in this sentence: knowledge isn't enough. And you might be totally familiar with the books in your area, whether it's emergency medicine or another area of medicine where you know the Bible's inside and out, Rosen's Emergency Medicine or Tintinelli's. you will still, even if you can phrase all of the pages here by memory, you will still make a lot of mistakes, And most of the mistakes that you will make will not be because of knowledge deficits. And that's why this is such an important topic, human factors in general, but in specific today, decision making. Because no matter how much you try to study here, you will not be able to compensate for the problems that you will face, and you might not even be aware of them. So if you want in modern medicine to be the best doctor for your patient, I believe that you need to know these things in the modern era. I like to talk about these human factors, and that is a bias of mine, and I might overstate the importance of it, but I believe that I'm right. And I usually talk to my to the people I teach who ask what is human factors, and I mean, I think it's easier to show than to like give you a definition. And so I usually show them this wall here, this brick wall, and I usually say that if each brick is like your knowledge, your book knowledge and your technical skills that you've practiced, then all of the murder, the glue that keeps all of these bricks together and makes them actually work in coherence, that is the non-technical skills. So one doesn't work without the other. You can be enormously skilled in communication and cognitive biases and so on, but you need the knowledge as well. And you can, as I just said, know everything there is to know factually, but you won't be able to work in the right, like in your environment, because you are unskilled in the non-technical skill department. People are usually somewhat skilled in both of them, and usually more in the knowledge department than in the non-technical skills, as that has been prioritized more in medical, like in filtering of medical students to med school, but also throughout medical school, that is more highly appreciated. But hopefully that kind of thinking is turning in these years, in these maybe last decade. Okay, so let's delve into a bit more about why this is important. This is Patrick Croskerry, and there is one figure that usually comes into his articles and into this literature that is stated again and again, and that is that in medicine we have a diagnostic failure rate of 15%. And I say in medicine, and maybe it's like 10 or 15%, but in the generalist specialties like private practice and emergency medicine and maybe anesthesia and also internal medicine, there is a higher degree of diagnostic failure, and there are different reasons for why there's a higher degree of diagnostic failure in these areas. But particularly in emergency medicine, we usually see time-critical patients, or at least our situation is time-critical. We are fatigued, we're decision fatigued, where there's a high task switching. There's a lot of, as we will go into, there's a lot of things that make the emergency department a petri dish for failure or for diagnostic errors. And that is what Patrick Croskerry calls laboratory of error, the emergency department. The figure of 15% can be argued that it might be too low, it might be too high, depending on so much. It's really, as some of the study, Gaber has done a great meta-analysis in 2013, which I referenced earlier, which states that there's a high variability within these 15%, and it's kind of it's hard to study this area. but and Elfstein, he made a he made a like an expert guess about these 15%, and as far as Croskerry usually says, then like through the literature, Elfstein's prediction has actually come true, and maybe it's a bit low. A study came out a few years ago stating that that diagnostic failures was the third largest cause of mortality in the United States after cancer and heart disease. So, I mean, this area, at least, you can argue about the figures, but and I'm not well read enough in this particular part of the literature to argue too much about it. But I think a lot of these diagnostic failures actually are important diagnostic failures. It's not just nothing. It's a lot of them are from autopsy studies where there was a major failure gone wrong. So it's not just non-important diagnostic failures. So we need to at least think about this area, just from this research. What is important is the opposite as well. Jeffrey Braithwaite has done a lot of studies on the complexity in emergency medicine and in medicine in general, and he usually states that, well, I mean, yes, maybe there are 15% or 10% diagnostic failure, but we do, in this enormously complex system, maybe the most complex human made system in the ever, which is the healthcare system, we only managed to do like 15% error rate. That's really, really good. So because we are thrown in, we as like monkeys, we evolutionary monkeys, thrown into a really, really complex system where we have to adapt to everyday situations, time pressure, and all of these things. So it's important to have this narrative with us as well when we go through this, that we are doing a good job. And this is a really, really, really complex job, and there is no easy solution. But as Croskerry wants to iterate, we want to decrease this error rate because we want to do the best for our patients. So let's try to understand a bit more about why is that we make these diagnostic failures. So Professor Croskerry usually says that there are three areas three reasons why we do these diagnostic failures. There are other reasons, and there are other failures than just diagnostic failures, but now we're just focusing on that particular area. So there's knowledge failures, like you didn't know that a pulmonary embolism couldn't be ruled out by a chest X-ray, or you didn't know that the patient with bradycardia, which you almost gave up on, was bradycardic because of hypotension. Hypothermia. And you checked everything else. So knowledge deficits are important, but according to Patrick Croskerry, they are not usually the main driver of the problem. I know certain experts and certain clinicians that I look up to see this differently, and I know that I believe that Eric Driver, among others, believe that knowledge failure oftentimes is an actual problem because the learners or the novice clinicians don't actually know a lot of the stuff that they maybe should know, especially in new and emerging areas like emergency medicine. Okay, then you have what you call error-prone conditions, and error-prone conditions are conditions where you are more likely to make mistakes. Where if you think of the situation that you're in as kind of almost as a trap, it's like a minefield of problems that can go wrong. If there are more mines, then it's much easier for problems to occur. And so error-prone conditions are like specific situations where there's a higher risk of diagnostic failure, and we will go into some of the issues in the end of this lecture. But some of them might be like fatigue, might be handover situations, might be what you call requito, where you have a high demand and there's not enough resources, so you kind of just try to do what you can with what you got, but that is not the same quality as you would if you had those resources, and so on and so forth. But according to Patrick Croskerry, the main area here, that is thinking failures. That is that might be that I usually deal up into suboptimal data gathering and suboptimal data interpretation. And I've made a thorough video about this as well. But thinking failures are usually a problem of gathering data. And when you have gathered the data, even if you have gathered the optimal data, optimal amount and high enough quality of data, then you don't interpret it right. So these two areas are enormously important, and that's like the main area of this talk. And the reason why it's the main area of this talk is that, like, Patrick Croskerry usually talks about this being 75% the cause of these diagnostic failures, partly or entirely. And you have to look up his lectures for the reference for this. I believe it's some older studies that. But no matter what, this thinking failures is a really, really important topic that we need to delve into as diagnosticians or probabilisticians and see how we can become better at it, both at the data gathering part and the suboptimal data interpretation part. And I've made a video going into these things, as I said. So I won't go too much into like the clinical aspects. In this video, we will instead go into the hypotheses and decision-making theories about this area. I think it's important in emergency medicine to acknowledge that when we talk about errors, we don't believe in emergency medicine we don't do diagnostics. We are not diagnosticians, as Simon Carley would say. We're probabilisticians. We don't care about what we care less about what the diagnosis in the end of when all the puzzle pieces come together, what the diagnosis was. We want in emergency medicine to be able to, with the data that is available to us, approximate the probability of time-critical conditions. And if we fail at doing that, then that is a process failure for us. But if we treated the patients as septic patients, and if we treated the patient as a septic patient with the data that we had, and it was correct at the time, but the end diagnosis became pulmonary embolism because they were subfebrile and they had hypotension and so on and so forth, then the specific treatment of sepsis was not a failure of us. So it's important to know that, like, when we've just talked about where we have 15% diagnostic failures, I'm not sure the literature actually is looking in the entirely right direction when it comes to emergency medicine. We might need to look at this from another angle, from the process and not the outcome, as Simon Carley as well would say in some of his lectures. And Eric Driver has in one of his lectures said, like, failure to approximate the probability of time-sensitive conditions based on available point-of-care information. That is what diagnostic errors is in emergency medicine. Okay. So that was a bit about why this is an important topic. And the take-home is, well, we need to know about these diagnostic errors and how to become skilled at knowing when we are in high risk of doing them, and how to improve our thinking skills, because knowledge isn't enough. Then we'll move on to System 1 and System 2, and And the main theories about of this topic of decision making, how we make decisions in emergency medicine and in medicine in general. Let's just do a historical intermezzo here. If we take this Cofidis paper that I referenced in the beginning, then they have given us an overview of the different areas of schools of thought into this decision making throughout the last 40 years. So you have your reasoning as a cognitive activity, and you have a more like a situation based. This is usually what you call the heuristics and bias school of decision making, that where some of the more prominent figures are Daniel Kahnemann, and they would usually talk about they would usually go to the laboratory and ask non-experts to perform a task, and they will show that they will make errors one after the other, what they will call biases, or they will be prone to biases in these areas because of our evolutionary brain that is not made for these kind of decisions. They would say that we are biased in these areas when we come into a specific scenario where we are predictably making errors. That is the definition of biases in their school of thought. Then you have the reasoning as a situated activity, which is a school that usually is called naturalistic decision making, or it's dominated by that kind of thinking. And one of the more prominent figures here is Klein. And these are the two schools that I am most familiar with. I'm not that familiar with the last school, and I believe that it's not really referenced that much in the literature. So I encourage you to check that out for yourself. So these are the two schools that we will be talking about, and that I'm familiar with. Okay. So in general, these two schools of thought, they look at problem solving, pattern recognition, cognitive expertise, and decision making. And Elstein, the grand old man in this area of medical decision making, he is in this kind of category. And then you have some of the other categories with which I talked about earlier, with illness scripts and semantic qualifiers. You have deliberate practice, which we'll talk about, and then you have heuristics and biases, which was the school I just talked about, with Kahnemann as one of the main characters. And then you have this naturalistic decision making, where you have Gary Klein as one of them. And I forgot to say, when these work in the laboratory, or at least Kahnemann and Tversky, then this school of thought, they study experts in their area of expertise, and see how they perform, why do they perform so well, and what kind of cues and what kind of things they are noticing, how they actually do what they do. And they are kind of in awe of experts doing their thing, whereas these guys try to point holes in the cognitive thinking, and try to create scenarios where the expert will not be able to perform as well as they usually would. So there, and this school of thought would probably would usually say that these guys are not they might be able to come up with laboratory scenarios, but most of the time the experts are actually doing pretty well. And these guys will say, well, even though experts are doing pretty well, then how would you know that these scenarios don't occur in reality? So this is kind of so in general, they are in agreement with each other, but they just prioritize different areas, and they come from different views. And there's a paper that I will reference where Gary Klein and Daniel Kahnemann they have put out all of the agreements and disagreements, which I'll reference shortly. a lot of these people have made books, and some of them are pretty popular. So you know where they like kind of stand on this spectrum of the research. Then you have Jeffrey Norman, who's made a lot of YouTube videos on. You can find them on Society of Improving Diagnostics in Medicine. Usually he talks about pattern recognition. Then you have Raoul Padwari, Catherine Lucy, and Scott Weingart. They've made a lot of videos about illness scripts and the semantic qualifiers, especially Catherine Lucy. And if you check out those videos that I referenced earlier, you will learn about those things. The deliberate practice, there is Anders Ericsson, and he's who sadly passed away from I believe COVID during this pandemic. But he pioneered this idea about deliberate practice, as opposed to the 10,000 hour rule, that deliberate practice is practicing the areas that you are where you have difficulty, instead of just. Earlier they said you have to go through 10,000 hours of practice, then you will become an expert, and that is and according to Ericsson, that is a problem, because you will not become an expert just by experiencing things if you're passive in that experience, in that exposure. You will just become an experienced non-expert, as Croskerry would call it. And deliberate practice is, well, if you're a musician, you will know that certain parts of a song, when you practice, are much more difficult than others. And if you don't practice the difficult, you should, when you go sit down and practice, you should practice the difficult parts, because if you can practice the difficult parts and know those, then you will be able to play the song after a while. And as Scott Weingart usually say, you have to do like micro skills. You have to go into like if you have a difficult section of a song, you need to go into the specifics of how you hold your hand and why is it hard, the specifics, like going from one string to the other, or one area to the other, and one note, from one note to another note, or chord to another chord, might be the difficult part, and you need to practice that specific thing. Like go into micro details, like and when you know that, when you can go into this like this kind of learning, then you shortly be able to like know the entire song, and you'll be able to not just do it, but you'll be able to. It will be impossible for you to fail at it. Scott Weingart has made a great video illustrating this called "The Pathway to Insanity" on Smack, which is available on YouTube. And he's also interviewed Anders Ericsson a couple of years ago, and you could check that out at MCRED. Then you have Daniel Kahnemann, who's made this book called Thinking Fast and Slow, where he goes into the System 1 and System 2 thinking. And then you have, Gary Klein, who I've referenced a lot, and I believe had a lot of great things to say about this area. And he's made he's made a lot of books, and one of the books the only book I've read from him is Streetlights and Shadows. He has made other books that are at least as important. I believe one of them called Sources of Power, and then he made some newer books which are kind of on the same topic. But this is a good book to start off with if you want to go into his work. Okay. This is just to say that, well, you might see these schools of thought as a spectrum of the individual and internal cognition, and the external, and whether the situation actually is the important thing. And this school that I didn't know too much about, according to the paper that I'm referencing this from, Croskerry et al., they talk about that this school of thought, as I believe, is believe that the entire thinking, decision making is very much situational rather than individual based. You need to be able to know the environment and control the environment, because the individual cannot actually do anything about these things. And the internal cognitive would be that, well, the environment doesn't matter too much. It's more the individual's thought process that is a problem. And Gary Klein's naturalistic decision making is somewhere in between these two, according to this paper. Okay, so let's go into some of the theories. And as I said, the two main schools of thought is Daniel Kahnemann's system 1 and 2 kind of thinking, and heuristics and bias, and then you have Gary Klein's naturalistic prime decision making. And if we just we will go through this theory in detail, but I'll just wanted to show you that they are kind of alike. They're not too different. So Gary Klein would say that in an emergency situation, you will think, well, is this situation typical or not typical? You see a patient. Is this a typical situation? And this is important. It's a situation. It's not as we talked about earlier. This is a situational thing. It's about the environment, and it's about more than just seeing a patient. It's also like the entirety of the situation. So if no, well, then there's diagnostic uncertainty, and then you might need to go through some heuristics, like thinking, like having some quick rules of thumb for getting through the situation. You can do the probabilistic thing, try to analyze the situation and weigh up likelihoods of pros and cons and so on. Or you could just do shotgunning, like ordering a bunch of tests and see what falls out. If you are, and then you'll get to the checkpoint, cognitive checkpoint. If you believe the situation is typical, and it's important, either you believe that it is, and it's not. This is not anything that is usually. This is a lot of system 1. You don't actually think about these things. It's just something that you fall into, and then you might be very like humble and calibrated in this area, and then you will think, oh well, then you will fall into this, or you might be a totally new learner in the very left end of the Dunning-Kruger spectrum, where you're on Mount Stupid. You are highly confident but not competent, but you will still think, oh, I know this, what this is. And both of these, the novice and the expert, categorize this as a, yes, I think this is a typical situation. But the expert will be much better at seeing the anomalies. Well, there's something off of this situation. They might not be able to put a finger on it, but they can say that this situation is not that typical, actually. They're doing some kind of checkpoint, which usually will be kind of a system 2 thing. And then they will go back to this like diagnostic uncertainty, as we just talked about, and then action. This is a lot like this this system 1 and system 2 thinking. That's why I'm saying these two schools are not too far apart. But there are important differences, and some of them are that, as I said, Gary Klein would usually, he says in his articles and his interviews that he will coil when someone mentions biases, because biases are thought of as irrationalities of thought. But I believe that Gary Klein would think that, well, they are important, these biases, but the expert in their environments will be able to, at least to a very, very large degree, adapt to these biases. So the outcome, when the expert goes into the situation and the outcome that the situation goes great, well, even though they might have encountered some things that there might be biases, well, it doesn't really matter, because they adapted through these, they compensated through these biases. Whether or not you call them biases or not, they just adapted to these problems that they saw, and they were aware of them. So the outcome became great anyway. So that's, I believe, the argument from Gary Klein, and there are more to this argument as well, but that's the argument that, well, if you're a well-calibrated expert in your field, in the real life situation, then probably you won't be as prone to these biases. Not saying that you are not at all, but you will probably be able to compensate, because that's what makes you an expert in their mind, as I understand it. And as I said, Kahnemann's research is a lot of mostly lab research, where this is more in the field. And so they disagree on the importance of like how important is it for the experts about cognitive biases, and then I guess they differ on the concept of algorithms, somewhat, but not that much. Like algorithms is usually what the rules and algorithms is sometimes what this school of thought, the Kahneman school of thought, will impose on novices, so that they can try to compensate for their lack of knowledge in the area and lack of experience, and that might be great for novices, but the problem is that we, as Gary Klein say, we are hindering people in becoming experts, because if you just do algorithms, then you won't be able to develop as a learner within this field, because you'll just follow the algorithm. And Gary Klein has shown several examples of where algorithms fail and where experts would prevail. And if you want to delve in more into this discussion, I encourage you to read this book and read this paper, which states this is the legendary paper called "Conditions for Intuitive Expertise: A Failure to Disagree," where they agree on a lot of stuff, but some of these nuances that I just talked about are some of them that they disagree on. And if you want a more more emergency medicine focused run through of these, then I encourage you to see Dr. Weingart's OODA loops and bread breaking smack talk. That's OODA, OODA loops, and he talks about this exact thing, that going through algorithms might be good as you're a novice, but you need to step away from the algorithms at some point to become an expert, and that is not encouraged within our field of emergency medicine and the safety culture that we are in currently. And that's one of the problems that I think relevantly is raised by the Gary Klein kind of school of thought. Okay, so like in general, these guys like to pick out errors, and they do find errors, and they are there, and but the importance of these errors are debatable, at least for the other school of thought. And these guys talk about like the skills and expertise of people, of experts, instead of like, they don't think the errors are that important because they will compensate for them. Gary Klein, in his Seeing What Others Don't and some of his articles, he usually draw these arrows here. So how do we improve in performance? Well, we have to take in both schools of thought, and that is what Patrick Croskerry also talks about. We need both the insights. We need both the talking about errors and knowing how to design the system so that especially novices, but also like more and more expert people will be able to not to a lesser degree fall into these errors of thought. We call cognitive biases, and thought. We don't think about these things. That's kind of a problem. So errors of thought is probably a misnomer, but cognitive biases we will call them. So, but we also need we usually forget this part. We do need to become expert. If we don't become expert, then we will never be able to compensate in this area. We will never be able to be what we actually need to be. And Gary Klein comes with the example of meteorologists, where the system has been changing for the last maybe 10 or 20 years or 30 years. It used to be like meteorologists would make errors and make errors, and then they would become better and better at it, and then they would become expert. But a couple of but in recent time, they have instead implemented algorithms to predict some of the weather forecasts that experts used to do. And when they test this, well, it is okay. Algorithms, they're okay, but it's not as good as experts. But in the area of meteorology, the vast majority of people don't need excellence, is their argument. They just need good enough, especially when there are so many who need to be taught this expertise, and through errors and through like teaching and so on, it's expensive. So that's why they've moved on to a lot of algorithmic thinking, at least for the majority of meteorological forecasting. And Gary Klein sees this as he understands why, but it's also a problem, because when we do need in certain areas experts, and especially in medicine where we actually do require excellence, then we really need a high level of experts, and then this really becomes a problem if we have only algorithms to follow and guidelines and so on and so forth. So we need to be our like critical thinkers. We need to also learn how to be experts, and we will go into how to do that in a little while. But let's first talk about this errors area, and now I'll go into the cognitive bias thing, the bread and butter of this lecture. And so we have this concept called cognitive and affective biases, and they can be defined through this, like the Kahnemann school would define them as predictable deviations from rationality. And it's important that they're predictable. So when you see some kind of situation, I see a patient, or I put a medical student into a room with a patient in a high fidelity situation, then I can probably predict that this medical student, if I set them up in a special way, if I set the case up in a special way prone to bias, then they will I guess you say commit these cognitive biases. They will be exposed to these cognitive biases, or they will illustrate that their thinking or their lack of thinking is biased, and they will veer off to a wrong diagnostic path. So that's why it's predictable. It's because we are, as I said, monkeys. Our brains have developed for a different task set, and it's important to have these biases in when we were cavemen, because you will rather run from the bush that is saying a noise. Better safe than sorry, so to speak. And it usually, like, these heuristics are usually good. But in more and more complex situations, as we are putting humans into, then we are more prone to errors, and we need to adapt we need to both adapt our thinking and mindware and the situation and so on, to actually be able to maybe compensate and not make so many errors, according to this school of thought. Okay. So let's go through the system 1 and system 2 way of thinking. So you have, in emergency medicine, or in medicine in general, this is from Croskerry's papers, and you have some kind of a patient presenting with a problem, an undifferentiated problem. And I'm not going to talk about like signal noise. Some presentations are high signal and they're quite easy to recognize, but others are more noisy. But in general, you have some kind of presentation. And as a clinician, either it's argued that we do pattern recognition here. So either you know this constellation of symptoms and the way they're presented, or you don't. And if you do recognize it, or you think you recognize it, like as I said, you can be a novice and be very, very confident of yourself, but like highly incompetent, and still think that you recognize this. You will go the same pathway as the expert who actually recognizes this because they've seen it times and times again and know what it is, or probably know what it is. So they go through this recognized pathway, and it's important to say that this is subconsciously. This is not something that, if you have to think about it, then you're already down here. So this is the area where you don't think about this, and this is system 1 you go into. This is like what we are in 95% of the time. 19 out of 20 situations or decisions are done under the radar, so to speak, is in system 1. System 1 is quick, it's efficient, and it's almost in most of life's situations, it's the one that you wanted to do the most, or that is why we do the most, because it's the most efficient. But in complex situations, and especially situations where you are not an expert, then it can become problematic. How we develop our system 1 and so on, we will talk about that later. But this is the true area of this is one of the true areas of the expert, is having a good gestalt or recognizability skill. They've seen a lot, they know a lot. Okay, then they go through this pathway to a diagnosis, and if you don't know the pattern, then you go into the system 2, which is much more laborsome, and the novice learner, if they are not overconfident, will usually go into a system 2 kind of process. And this system 2 kind of process, optimally, it's a probabilistic process where you have a high amount of critical thinking and rationality, so that you can kind of be aware of, well, what are the pros and cons? And these are some of the things that I've gone through in some of the cases, especially in my neurological lecture, how to do this. So I won't go through it here, but this is probabilistic thinking, Bayesian analysis of the patient. Well, the chest pain was sharp. It was it came abruptly. There was pleuritic chest pain along with it. Well, there's a higher and higher risk, higher probability of this being a pulmonary embolism instead of this being ACS. But it might still, the probability of ACS can present atypically. So we should maybe do it. This is the kind of reasoning that you do in system two, whereas system 1 would be, you don't even think about it. You say, well, chest pain, clamming chest pain, you see the patient actually, you might have cues, like you see the patient clamming their chest, they're a bit old, you might have seen that they're a smoker. You connect these dots in the Gestalt pattern, and once you see the pattern, it's hard to unsee it. But then kind of like a Rorschach painting, and then you go through like this is the ACS, and like 9 out of, like, if you're if you are a well calibrated expert who's seen a lot, you've seen the typical and the atypical, and you've done deliberate practice and so on and so forth, then you have great pattern recognition, and then you will be able to say, like, well, this is ACS, and then you will 9 out of 10 times be right, and the 1 out of 10 time you might not be right, then you might be able to compensate for that, maybe not. But if you have if you're not the well calibrated expert, but you're the novice who's gone through this, then you might be wrong. Then you might be right only like 4 out of 10 or 5 out of 10. Like emergency medicine, a lot of this is also that we are lucky. A lot of patients actually don't have time critical conditions, even though we think that they have. A lot of studies show this, and you can just think about, well, a thunderclap headache, 10% of them have subarachnoid hemorrhages, but and some studies and some experts in this area might say that, well, maybe 20 or 30% of them have time critical conditions, but 70% 70% then would only have will only have the headache, non-time critical. So like just by chance you will be right there in 7 out of 10 times if you send home a thunderclap headache. So there's a lot of luck as well, because a lot of the things that we think are high risk aren't as high risk as we actually think there are. Not that they shouldn't be worked up, but risk is hard, as Simon Carley has said in his lecture, Wrestling with Risk. Okay, so that's the main thing, like the very laborsome system 2 and the not so laborsome system 1, which is more prone to these cognitive biases and errors, especially in the novice learner. Then you have these things in the middle that I want to talk about. Overlearning and practice. So if you do deliberate practice, and it's important, this is deliberate practice, you reflect upon your practice and you do cases, you think about how you can improve from these scenarios that you've been in. Then you will at some point, when you've seen a lot of chest pain patients, then you will at some point actually be able to do this process of seeing the ACSs without actually thinking too much about it, or actually not thinking about it at all. This is the way to, like, this is the route to expertise and to adaptive expertise, that we become better and better and better through deliberate practice. And so if you see like a timeline of like the novice learner and the expert learner, then you would see that the novice learner would use much more system 2 because there's less things that they recognize, and even the things that they do recognize, they probably don't recognize at all. They might just be lucky. But then as they increase their through deliberate practice and experience, then they will use much more system 1 because after some while they know. Okay. Okay, so that's that pathway. Then you have some of the other things here, and there is there's one thing that's really important here. Sorry, and that is system 2 and system 1 should not be thought of as separate processes. They probably toggle in between. Usually Croskerry has a toggle button here as well. Like we jump in between these two processes back and forth throughout the entire diagnostic process. We don't just do one and then do the other. You might recognize parts of the history and then you don't think about that, but then you think about other things that, hey, that's an anomaly. And so we toggle between these, but and system 2 is kind of, you might think of system 2 as the police in this kind of scenario. They are surveilling your system 1. They are checking they are unconsciously checking when anomalies arise, and enough anomalies arise if you are aware of them. They are checking that, hey, maybe we should go into system 2 now and actually check whether this is really that what we think, and do a more systematic analysis of this. The problem is, and that's why I put in a battery here, is this surveillance thing it drains with time. And in emergency medicine, that's kind of why we also have this laboratory of error sign on us, because with time this drains. From beginning of your shift to the end of your shift, you become more tired, you become more task loaded, cognitively loaded, meaning that, well, you only have so much bandwidth, you only have so much thought power. So when you think that you're multitasking, you actually aren't. You can only task one thing at a time. So when you become cognitively overloaded, you might focus on like you might be what you call heads down in a specific situation. You might like not be able to have an overview at all because you're doing a very complex task, and so on and so forth. Like so you might be interrupted a lot, and you might suffer from decision fatigue after a while. So this surveillance system, through fatigue, through all these things, it becomes worn out. So at the end of the shift, there is even the things that you probably should have gone this way with, you'll just say, oh, well, I think your brain just says unconsciously, I recognize this stuff. I'm sorry. And you'll probably not be able to override this process. So that's why, as we will talk about, it's important to build in mindware, or sorry, build in some kind of stops in your thought, like habits. You need to develop habits of knowing when to override your system one. I know if, for instance, in the end of my shifts, I am worthless at hard decisions. So if I do get a patient where I think, okay, this is a high risk decision, it's like a patient with borderline who comes in and has atypical symptoms, I might recognize it as atypical symptoms or not. I just go ask my colleagues, could you please run through this case with me before I do anything stupid? Because these are the times where we actually do stupid things, especially also when you hand over your patient after your shift. Okay, some of these things that you might be able to do, you can ask your colleagues, you can do forcing strategies. We'll get into that in a little while. There are other errors here as well, and you can sometimes, like, your system one can sometimes, well, you might be right. This was herpes zoster. You recognize it's right, but you become in your system two, just sometimes you become, because you just heard this lecture and you are afraid of cognitive biases everywhere. Well, then you might just go over into this rational override, or you will become paralyzed because of you are analyzing too much. So there are processes here that can interfere with each other. There are maybe I think that is a good introduction to this model, and I might have forgotten some things, but I think that is the brunt of it. Okay, so Eric Driver, in one of his lectures, put out this 012 kind of way of thinking through the diagnostic process. So in the beginning, the beginning is represented by Mr. Bean, because that is, you have to be, in my interpretation of it at least, you have to be open, you have to use open communication to not be exposed to what you call unpacking error, where you just cut off the patient too early, and you will never know what you don't know that they actually were going to tell you, which might have been important. So sit down, open-ended questions, and listen actively to the patient, have a conversation, and so on and so forth. I've done an entire lecture on the Mr. Bean part, and the like, where you kind of find out what is the problem here, and gather data. And then you could go on to the system one and system two. So in the beginning here, there's more data gathering, and then as you go along, you gather enough data to be able to start interpreting some of this data. And this first thing, as I said, focuses on what is the problem. Like, the patient comes to you with some symptoms, undifferentiated symptom, but we all know that, well, what is on the chart doesn't mean that that's actually the problem that they're here for, especially elderly with non-specific complaints. So it's important not to anchor down too early here. You have to keep an open mind, and as Gary Klein would say, usually some like diagnostic process can be they usually talk about, well, you just have to put the puzzle pieces together. But Gary Klein usually says, like, well, it's not like that. That's a bad analogy, because you don't know what the puzzle pieces are. You do know kind of what puzzle pieces look like, but you don't know which ones are important, and the patient is coming at you with a lot of puzzles. So it's much more a lot of puzzle pieces that might not fit together. So when you're sitting there with your patient, you're taking in a lot of information, and you need to sort through this information. And that is, Gary Klein would say that this is much more like taking maybe 6 or 7 puzzles and mixing them all together, some of them fitting and some of them not with each other, and then trying to find out which pieces are important. That's a better analogy, because you don't know what counts as a puzzle piece in the problem that the patient is talking about. You need to find out that with the patient, and sometimes you have to ask them, is this a puzzle piece? Is this actually important? Now that is, I mean, the patient might say that is not as important. I had a patient here the other day where the ambulance had gathered the history where they had focused on chest pain, and the patient came in as a chest pain patient, as a prio 1 patient, like on a resus room. And when I asked the patient after going through the ABC, I asked him, well, just tell me what the problem is, like an open-ended question here, and not taking into account what the ambulance people had said, even though I had it in the back of my mind, and that was what I was working up. I just wanted to know what the patient thought was on it, and the way the patient framed the history was totally different. This had not that much to do with chest pain, more so with uncomfortability in the chest. But the main issue was that he was out of breath, and that he was having palpitations. And he was going in 200. His pulse rate was 200. So this. I mean, sometimes and I asked them, so is your what is your most important problem here? What is your most important of these symptoms that you talked about? What would you say is the problem? And that was the dyspnea and the palpitations, not the chest pain. So that made me think about this being probably more a secondary thing to the heart rate rather than the primary driver. And I worked up for ACS anyway, but I mean, but you need to, in the beginning of your diagnostic process, you need to keep this open mind and actually try to avoid these cognitive biases that you might fall into in the beginning through forcing strategies and so on, which we'll come back to. Okay. Then your system 1 will unconsciously ask, do I recognize these puzzle pieces? If you do think, if you're beginning to think, well, do I recognize these puzzle pieces? Then you are in system 2, all of a sudden. But what you actually need is that you need your system 2 to kind of override when you've done this part. And you gather your puzzle pieces, and you think, what is it? Then the argument is, well, before just heading on, especially if you're a novice, then you really need to think about, am I sure about this? And sometimes there isn't time for this, and then you have to in emergency situations, and then you have to just make the call. But usually there will be time, and you have to think about, am I sure about this? And go through some kind of probabilistic forcing strategy. Well, name the 3 most important differential diagnosis here. Okay, that would be chest pain, pulmonary embolism, and maybe aortic dissection. Okay, what are the pros and cons of this? Well, the pros and cons, or what says that this is ACS and what says that it isn't. Okay, go through that. And what data do I have? Do I need more data, or do I just need to interpret the data that I have? These are the kind of and okay, so there's a low risk of this being aortic dissection, but it is an old person, and I have a low threshold to work that up. So should I do a chest angiogram before actually doing the getting the patient to the cath lab, so on and so forth? That's so you need to you need to kick in your system 2, and how to do that at the right time. That is like that's the main brunt of this problem, and this research, because you need to do your system 1 almost all of the time, because if you do system 2 all the time, then it's super inefficient and it's really laborsome, and oftentimes, even though you might be right, you can also be wrong, and you can be paralyzed by your analytical mind. But there are some errors that can be made here, and especially if you're a novice. So you also need this, and the way where you go from 1 to 2. When are you going to go from system 1 to system 2, or when are you in your subconsciously mind going through a process and then suddenly actually noticing an anomaly? Well, that is the $1 million question here. How do we do that? And probably the answer is not one thing. It depends on which situation you're in. It depends on designing your system so that you're not fatigued, tired, or so on. It depends on designing yourself and making yourself aware of things, like developing habits of, okay, every time I come to this point, then I need to go through just the basic things, like what a differential diagnosis. I just take 2 minutes here, stop and think. There might be there might be different cues. You develop these cues just as when you train or you are out at working out, and you have cues like straighten your back every time you feel something. Every time you feel like your back is aching when you're squatting, then then I raise the chest. Or you have some motor cues. You have cues that you feel in your body. You have cues that you when you hear certain information, then then I have to kick into system 2, and developing these cues and developing habits as well. That is, I mean, that's probably like the short answer to how we get good at knowing when to go from one system to the other. But yeah, we'll delve into that in the end of this lecture. Exactly, becoming well-calibrated expert at system 1, so that we have that. The challenge is like becoming good at this, and as I said, not overusing system 2, but using it at the right time, because the 2 systems are we need both, and they are intertwined. So, okay, this is from the Cognitive Autopsy by Patrick Croskerry, and it's like he goes through 42 cases, I think, and then he just places these for a bit of fun on a chronological time scale and when they present. And you see that I usually tell my learners and tell myself as well, like in the beginning of each encounter, there's a lot of information that you need to, like, this is one of the highest risk areas where we have anchoring, framing, and availability bias, and ascertainment bias. And I mean, the earlier we encounter biases, the more higher risk we are, at least as novices, to snowball into all of the others. So I've made my video in English as well and in Danish as well, called Probabilistic Thinking about Headaches. And in that video, I go through all my arguments for why I think the beginning of the encounter with the patient, both like from a compassionate care kind of standpoint, but also from a diagnostic standpoint, is so enormously important to get right. And to get that right, you need to be an expert communicator. And that's why I think emergency physicians need to be expert communicators, even in non-high fidelity situations, because most of our patients are not on high fidelity. They don't look sick, but they might be sick. And you need to get that information. And how do you get that information? By being good at communicating and gathering data from the patient, and not doing what you call unpacking bias, where you cut off the patient and don't get the information. Okay. So this is also like a kind of an overview of all the biases. There are like maybe 150 cognitive biases, maybe more. And we don't go through all of them, but I'll just go through a few of them. Yeah, and the snowball effect is like this thing where you actually can snowball into all of them if you are encountering biases early on. Okay, so just to name some of the biases. Affective bias, sometimes we call it, sometimes that is part of the cognitive bias in literature, sometimes it's a separate bias, but in general, affective bias is well, we all have biases, and biases are neutral. It's not like they're negative as they are in other areas of research. Biases are neutral. They're just something that happens. The consequence of the bias might be a problem, but that doesn't mean that they're bad, because some biases are really good. We need to be able to have these biases. We need to be able to have our thinking as a ape, because it's useful and it's effective. It's just not that good in all situations. That's the thing. And the same with affective biases. Like, we all have some, well, you can take a test on the internet from Harvard, seeing what kind of affective biases you have. Whether you're prone to being a bit biased towards elderly, or towards people of different races or ethnicities, of different color, of different body mass index, of gender, of so on and so forth. We all have some kind. We are all somewhere on this spectrum. So that's why it also doesn't, like, being aware of your affective biases is much better than just like shaming people that have affective biases. Just, well, if you're aware of them, then you can probably try to work on them and develop them. And at least you can compensate for them in the situation. So if you know that, well, I might be a bit biased negatively, I don't like having to do with people who have a drug abuse problem, or I don't like children in the emergency department, so on. Then the solution to that problem is that, well, when you encounter patients that you do not like, then you should really use that as a cue to systematize your thinking and use probabilistic thinking more analytically than you would otherwise. And it also is people you love. So when you, especially when you have, well, some relative who asks you about a problem, or if you know the patient, or so on and so forth, then that can also be a negatively or a risk of bias here. So doctors are encouraged to be a bit cautious when giving out advice to both people they hate and love. We should try to be. We shouldn't be neutral. We are human beings, but we should be aware of our affected biases and where we stand on the different spectrum on different population groups and so on. Okay, anchoring and adjustment bias is where you fixate on a specific piece of information in the outset of the diagnostic process, and you put too much weight on it. So you base the entire entire diagnostic process on that piece of information. Well, if for my example earlier on was like, well, I should just pick the chest pain from this patient that the ambulance has said, like, well, if I had just anchored on chest pain, it was a situation where chest pain was the issue according to the ambulance, and that's why they called in for a pre-01 resuscitation bay opening, resuscitation bay handling of the patient. But and it's important to anchor. Like 7 out of 10 times they would probably be right. So we need. That's why I still have it in the back of my head when I go through like my questioning. Well, this might be chest pain, but it might be something else. So anchoring is good, but you just need to be able to, if new information comes at you, or you need to be able to open your mind towards it might be other things when you go through your history and physical. Okay. Confirmation bias is something that is coupled often to anchoring bias. So confirmation bias is that we only seek information that like confirms our hypotheses, like our zero hypotheses, our null hypotheses, sorry. And that's the exactly opposite thing of what we actually should do. We should try to falsify our initial hypotheses, but usually we don't work like that. That's like a system 2 way of thinking. Like, oh, what doesn't speak to this being an ACS, or what doesn't speak to this being long pulmonary embolism. So when you anchor, oh, this is just a drug seeker, or this is just a borderline patient who has taken too many drugs. You just seek out the information that confirms your initial hypothesis, then that is really a strong and problematic problem that we use all the time. That is a very. So my girlfriend had a case a lot of years back when a patient also came in, a borderline patient who had who's been vomiting, and the ambulance personnel was like, "Oh, you're not sick. You're just acting out," and so on and so forth. And they were probably anchoring to the borderline thing, and then they were confirming their bias because they said, "Oh, you are throwing up because you took too many drugs," or whatever. Like they explained it away with this. And the thing is that patient had a really serious abdominal condition. The reason why. So these can be powerful problems. Okay, ascertainment bias is that we see what we expect to see, and that's kind of the a lot of these biases are overlapping. So this overlaps with confirmation bias, that we think that we're going to see, or if you have a patient who presents with heart failure and they say that they're non-compliant with their heart failure medications, well, then you will probably just say, "Oh, that's the reason," and not go systematically through, well, it might be ACS, even though that you're not taking your medication. It might even be a high risk of ACS because you're not taking your medications actually as well. So that is ascertainment bias. Availability bias is that we remember things that things we remember will be judged as more likely. So if I, off the top of my head, can remember, I can remember, the reasons for ACS, the reasons for heart failure are, well, it might be pulmonary embolism, it might be ACS, and you're forgetting some of the more rarer things, or the things that you don't remember. Well, then you're not remembering them, and then you won't be checking them out. Patrick Croskerry, in his cognitive autopsy book, has a example with a patient that was worked up for bradycardia, and they went through all of the, like, no drugs, no electrolytes, no ischemia, and no other like arrhythmogenic causes from the heart. So they thought, like, well, there's nothing wrong with this, or the reason why this patient is still bradycardic is undetermined, and there might be toxicology reason, and they forgot to check out that this was hypothermia. So sometimes a checklist can be good here, but this is a good example of where you might be paralyzed by analysis as well, because, I mean, an expert would treat and then see if the treatment actually does anything to what they're treating, and if it doesn't, then that's maybe a small anomaly, and if it keeps happening like that, then it's a big anomaly, and then they have to change path. That's what you usually would do. That's the OODA loop kind of way. That's the adaptive thinking. But if you're not aware of the feedback loops, then you will not catch on to these biases. And that's, I guess that's Gary Klein's argument, that an expert would probably see the feedback and know when to change direction and change up the plan. Okay. Then you have the framing effect, and again, the ambulance personnel, in my case, they framed this as a chest pain patient. Another example is, every time I get epileptic patients, then or someone who is having a seizure, then then usually they will usually say, well, he's having an epileptic seizure, and I will always, my personal forcing strategy here is that I just take a step back and say, well, the patient is having some kind of episodic movement. Why is this patient having specifically a epileptic seizure? Well, then I can force myself to describe the semiology, or force the ambulance personnel to describe the semiology of the patient, and I can compare that with my illness script of epileptic seizure, which is like, well, it should only last 2 or 3 minutes, and if it's not, then it's a status, and you have to have, like, both sides should be moving if it's generalized, and usually you have open eyes, and you usually have lateral tongue movements, so on. I have a pattern that should be checked with that. So and that's how you can avoid the framing effect sometimes. Like, and the framing effect is about, well, a problem is presented to you in a way that that biases you towards that particular problem. So in my case with the part patient, they were framing it in a way that encouraged me to think about chest pain and not as much thinking about all the other stuff that actually was the reason for the patient's problem. You can also call this diagnostic momentum. If the ambulance has made a diagnosis of ACS, or likely diagnosis of ACS, then it's really hard to change that. There's like inertia behind the amount of energy taking to, like, stop, wait, we need to check that out. And that's for an emergency physician, that is hugely important. And that's why we stress that we don't make diagnosis unless we're really, really, really sure. Because if we make a diagnosis, then when the patient is admitted, it's really hard to get turn that cruise ship around to when you're a doctor on the ward to say, well, the patient was admitted for pulmonary embolism that was diagnosed in the emergency department, or sepsis, and that was diagnosed in the emergency department. Well, then it's hard to, like, stop and think analytically about that, and just usually they will just go on in our way of thinking. So that's the power of diagnostic momentum, and where you can miss a lot of things. I'm not saying that you should not trust your colleagues, but I think you should at least speak in modest terms when it comes to probabilities of disease, especially in the early hours of a patient presenting with undifferentiated symptoms. This can probably be fixed with forcing strategies, and also with culture, where we don't, like, the thing about diagnostic guarantee that exists in Denmark, or we have this, like, you need to have a diagnosis, also in the emergency department, is totally horrendous. It probably comes from the literature where it says, like, well, if you have a diagnosis, then you can treat it. But the problem is, in the early hours of a symptom presenting, then you should not diagnose something. You should probably stay away from. Don't say anything that you're not sure about. And then let time will rule out the things that you need to rule out, and if you can't, then admit it, and admit the patient and work up and treat as such. But you shouldn't put the diagnosis label on until that your time has passed. Time is the best test, and you're more sure about it. So we should develop a culture of a probabilistic language that is pragmatic as well, instead of just, like, absolute language, like this is this diagnosis, this is that diagnosis. Okay. Fundamental attribution area is seeing what kind of a person has the illness and judging from that instead of viewing factually. And again, this is one of these, well, if I see in Denmark, if I see someone from Greenland, then I would probably work up the patient for tuberculosis if they have a cough. And I might suspect that if they're not taking the medication, it might be because they are drinking. This might be viewed as racist or as biased or xenophobic, and that might be right as well, because it's like a systematic way of thinking about a patient or a person, and I'm using that not against them, but try to help them with it. But the thing is, it's also something that I might be right about, maybe I don't know, 6 out of 10 times, 7 out of 10 times. But the fundamental attribution error is that I stop I don't think about the times when I could be wrong about this, so I don't think wide enough about, well, 4 out of 10 times it might not be tuberculosis, and they might not have a drinking problem as the cause of this. It's important to not throw out the baby with the bathwater with these biases. These biases are there for a reason. We're thinking like this for a reason, but we need to like monitor our thinking. And if I to be able to like treat everyone equally and effectively, and we probably shouldn't be too quick to call others racist and so on because of these things, because they are actually like statistically not proven but likely, and until if the statistics change, then we should change as well. That's the thing. If we need to gather data to be able to like inform our decisions, and if the data changes, then we should change as well. Hindsight bias is one of the very important biases for emergency physicians, because usually when we see emergency physicians, if we have usually when we see a patient, then we don't really know what's wrong with them, and we send them up into the ward where we try to treat them for the things that are that we cannot decrease the probability of. For instance, like sepsis. If you have a feverish patient who has a hypotension, it might not be sepsis, but it would be wrong of you in most cases to not treat it as such. And the patient on the ward afterwards might say like, why did you, why sorry, the doctor on the ward might say afterwards, well, why did he treat it like that? It's obvious that it's this and this diagnosis, but that is hindsight bias, or the retrospectoscope. We have all of the like it's a bias of seeing something in hindsight, but that in hindsight looks obvious, but if you look at it prospectively, it was not obvious at all, and we needed to treat certain things to reduce the risk of the patient dying. Then you have commission and omission bias, and commission bias is doing too much, and omission bias is doing too little. Commission bias is probably something that we do in the emergency department because we have little information. We are more prone to doing than not doing. And Gerben Kaisers and others have done this great article called Don't Just Do Something, Stand There, Deliberate Cognitive Inertia. And Jerome Hoffman has also talked about this. And it's important to, like, commission bias is something that we need to be aware of. And sometimes, I mean, what we actually want to do is do the right amount of things for the right patient. But sometimes it's really hard because it's so complex, and there are so many there's so many problems and so many error producing conditions, and it's time pressure and so on. So we will always overtreat or undertreat certain populations, but we just need to undertreat and overtreat the right populations, so to speak, so we get a good hit rate. And I think it's important to think about, I think, Ruben Strayer and Scott Weingart's concept of preferred error with omission and commission bias, because we are going to do one of the things a lot of the times. So in a high-risk patient, we probably should do more than less. And in a low-risk patient, we probably should do less than more. And the preferred error paradigm is that, or idea is that we are going to make a mistake no matter what. We should do the thing that fails the best in this scenario. And the problem with the preferred error thing is that, well, we are more and more, as Jerome Hoffman talks about in his BMJ podcast, about this culture of overdiagnosis, is that, well, we are more and more saying that it's problematic for the physician to miss anything. So then the commission bias becomes much stronger than the omission bias. Okay, we have search satisficing. Search satisficing is like you look for you have a patient presenting with chest pain. Okay, I found I found pericarditis, or I found pericardial effusion. That's the reason for the chest pain. Stop, like done deal, slam dunk admission, and you might miss the cancer that is on the lungs. That is producing the so search satisficing is if something you find one pathology, and when you have found that pathology, you stop searching for more. So and then it's kind of like you have the emergency saying that, well, in when looking for fractures, like always look for the second fracture, because the second fracture is the one that is missed the most. That's the most commonly missed fracture. So then you have Rakito, and Rakito is like resource availability continuous quality improvement trade-off. That's actually not a bias. It's wrong of me to put it here, but it's an important concept that, well, the less resources we have, the lower accuracy and quality we can produce. And it's more like an error-prone condition than a cognitive bias. That like in certain situations we will not be able to, like if the department is crowded and we are expected to like do a certain thing, then we will distribute the resources so that the quality will be lower, but it will be as good as it can be, as good as it can get. Then you have premature closure at the end here, and premature closure is kind of too early in your Mr. Bean kind of thinking. You stop thinking about other diagnoses and you just say, well, this is ACS. If I, in my case, had just taking everything that the ambulance personnel has said and just say, well, this is ACS, of course it is, or then that would be premature closure, and not even thinking about pulmonary embolism or other causes of chest discomfort, or even thinking about, well, maybe we should do a thorough history on this patient before jumping to conclusions. Okay, so that was the errors arrow, and that's where a lot of the current mainstream focus in the patient safety movement and so on has stopped. I would say they mainly focus on the errors, or it's at least over prioritized, and they have not delved too much into the insights and expertise, as the meteorologist experts that are being like pushed away because of algorithms and we should not make errors and so on. We are lacking expertise, and we are missing out on a lot of the reasons why we're making diagnostic errors if we don't look at this part as well. So let's just take a quick look at what an expert is, and to gain a little bit of insight here. So what is an expert? Patrick Croskerry has made this version of the System 1 and System 2 thinking, and as I said, like if you remember this, the first line between System 2 and System 1 was this: with practice, you will become your System 2 processes will become System 1. Okay. You can, and he put up 3 levels of expertise here. So you're a novice, and then you become an advanced beginner, and then you can become then with exposure you will become experienced. But you will just, if you don't do deliberate practice, you'll become an experienced non-expert. You will be someone who has a specialty but has not amounted to the expert level. Then the next area here is that you actually do deliberate practice and so on, and then you become what you call a routine expert in the literature. And then the the guru kind of thing is like you're an adaptive expert, and that is the highest level, so to speak. And how you go from, so let's talk about how you go from these from being an experienced non-expert to routine expert to adaptive expertise. So there are certain elements that need to be put in here. First of all, you need high validity environment, and that is something that comes from this science area. of decision making. You need high validity environments, meaning that they need to be predictable. Certain environments are not predictable, like the stock exchange. They are unpredictable. Even all the cues that you get, all of the like the signs, and like, oh, that is going up, that means that this will be going down tomorrow. So even though some of these signs in medicine might be complex, they are usually somewhat predictable, and you can learn from them. They're not random. But in the stock market exchange, they are random. At least to the human brain, they are random. And Gary Klein and Kahnemann in their paper describes this as, we describe task environment as high validity, meaning it's high validity was what we wanted, what we need, because if there are stable relationships between objectively identifiable cues and subsequent events, there's a causation between them. And between cues and the outcome of possible actions. Medicine and firefighting practice in environments of fairly high validity. So certain environments are so random that you can never teach, or you can never learn anything from them, because either the cues are so subtle that we cannot see them, or we cannot know them, or it's really just random. And even though we know we can see certain cues, they don't amount to what we expect. Never amount to expect. It's random. And the stock exchange is one of the examples that Gary Klein and Kahnemann gives. And then sometimes in these low validity environments, what is important here is that you can sometimes you can put in algorithms there who can outperform any human, because humans cannot become experts, and sometimes the algorithms can somehow learn by machine learning in these environments to perform a bit better and see maybe cues that we can't, maybe in other ways. But to become a human expert, you need these high validity environments. You need also deliberate practice, and I gave you my music example of what deliberate practice looks like. And if you want to learn more about this, look up Anders Ericsson's book Peak, and check out his EMCrit podcast with Scott Weingart. Then you have feedback, and you need to be able to do deliberate practice. You need to get feedback both from your environment and from your colleagues, and you need to have you done something wrong? Have you done something right? You need coaching. All good athletes at Olympic level and so on, they all need coaching. Even the best, all the time, need coaching, because you can always become a bit better, and you can always move a bit right when you you move to the left and so on. And you also need the ability to see it. You need to be able to to be humble about your blind spots, and the ability of a coach or a partner or a colleague to actually see it. And all the intricacies about this is detailed in Thanks for the Feedback. I've done videos about this as well, which I will reference in a little while. And I've done blogs on this on akutmedicin.dk as well, on feedback theory and how to become feedback, or how to get the most out of feedback. And also from Simon Carley. Simon Carley has, in Saying the Evidence blog, made a lot of both videos and blogs about this area. So please check that out. And then you need a culture as well. And this is Daniel Coyle's The Culture Code, a book also recommended by Cliff Reed from the Sydney Hems. And this book talks about so maybe you got all the stuff that you need for good feedback, but you don't have a culture where failures are okay to talk about. If you don't have a culture of psychological safety where it's okay to talk about failures or okay to come with critique, well, then you can never grow as a person, because you will not dare to mention all of the problems that you are facing and that you're doing, and all the failures that you might be doing and errors you might be doing. So you need all of these things at least to become an expert. Then going from routine expertise to adaptive expertise. And as I understand it, the routine expert does still make mistakes, and the adaptive expert makes much less mistakes, because they adapt to the environment. They take in new information, and they can twist the scenario and replan their plan because of the new information. So, and here Patrick Croskerry talks about the mindware gap, where what the adaptive expert has that the routine expert has a bit less of is rationality, critical thinking, metacognitive processes. They can think outside of the box. They're flexible, creative, and innovative. These are all things that can be taught through cases and through feedback and so on. So it's actually kind of this as well, but it's just to a larger extent. And there might be nuances of this, but in general, this is like the way to go from to here. And it's important that exposure is not the same as deliberate practice. You need active participation and thinking on reflection to become an expert. Okay, and this is also mentioned a bit more tongue-in-cheek by Scott Weingart in his Reset Rankers video, which can be found on Vimeo if you Google it, and also on IMCRED. And he asks, how many of your specialists are adaptive experts, and how many are experienced non-experts? So how many consultants have you had that actually don't mention, where you feel like, well, maybe they're not good enough for the thing that they're talking about? I mean, I think we should also always be good colleagues. It's true that peers are better at seeing your flaws than you are yourself. So you might also be overconfident and tribal in your thinking. So I think you need a lot of data to be able to say that someone in your department is not an expert of your specialists. But Scott Weingart raises a critical point here that like some of us will go through med school and through our medical career not developing any expertise because we're just experiencing. We're not doing deliberate practice to the extent that will make us expert. That, I think, is the takeaway. So how do you know someone is an expert? Well, there's a lot of definitions of what an expert is. Some of them are from Croskerry and Daniel Kahnemann and Gary Klein. They talk about an expert is someone you usually cannot say that yourself is an expert because you have blind spots and you don't know. But usually it's by asking your peers, well, who's the expert at this in your department? Who's best at this in your department? Well, usually they will know. That's one of the definitions. Another definition is an expert makes mistakes, but they reflect on them. And that's not, I mean, it doesn't make you an expert just because you reflect on your mistakes, but they will more often than not actually try to adjust their mindset, adjust their mindware, and update their illness scripts and so on when they do make mistakes. And I guess that's also part of the mindset of feedback. Like, no matter what kind of feedback you get, no matter if it hurts, you will try to get those 2 or 3% out of it. That was important. Like the spotting the right, as I usually call it, instead of spotting the 97% wrong about the case. Okay. Usually they are humble enough to know what they don't know. So that comes back to the Dunning-Kruger argument that if you're overconfident and you don't know anything, like people who are overconfident, we are all overconfident in certain areas. We tend to think that we know everything in the area, and experts usually will kind of narrow in where they actually can talk about stuff that they know about and not know about. An important thing is that you have something called fractionation of skill, and it talks to this know when they don't know kind of thing. Because fractionation of skill is that you might be an expert in one area, but that doesn't make you an expert in another area. And how little an area you can be an expert in and not be an expert of an adjacent area is up to debate. But is it that you are an expert at emergency medicine but not at nephrology? Or is it that you're an expert at communication in emergency scenarios but not at communication with patients? Is it, I mean, so you can like micro this down until you have really small area of expertise that so it's but in general it's more to say that people who acclaim expertise in one area, especially when you're on TV, and maybe they're an expert at one thing, but they are certainly not an expert at other things, but they're still asked about other things. Like celebrities are usually asked about their opinion on things that they're not at all experts at. That's a common thing, and that's fractionation of skill. That's probably not someone who are expert, and we probably shouldn't listen to them. And then experts are usually in their own environment. If it's a high validity environment and they have become expert, have reached expertise, then they will usually be better than algorithms, or at least as good at algorithms. It depends on the area and so on. But that is also one of the things. If you want to know more about what makes an expert and how to become an expert and in emergency medicine and what the literature says about these things, then I've made an entire video about this. You can check out. It's in English as well. So what can we do? This is the end of the lecture. What can we do to both become experts, but also try to decrease our errors, our predictable errors in different situations? I'll begin with just saying that, well, all human decision making necessarily involves both intuitive and analytical decision making, and the trick lies in knowing how and when to get the most out of each mode. As we talked about earlier, none of the type 1 or type 2 processes are bad. They're just different variations, and we need both of them, and we need to use them efficiently, and that's the key. How do we use them efficiently, and how to become experts at system 1 and and proficiently critical thinkers in system 2, and knowing when to toggle between them in situations. Perfectly rational decisions can be made in intuitive mode, just as irrational decisions can be made in analytical mode. And we have talked about a lot of the biases that are like attached to system 1 thinking, or not thinking, but in system 1 processes. And just quickly here, just talk about like, well, in analytical mode, you can analyze and be paralyzed by your thinking. You can also be irrational and slavishly following guidelines and rules, and not that are not other and not other guidelines. And you might sometimes, well, one of the problems, like if I read here, it can be just as irrational to slavishly follow clinical decision rules or other analytically derived guidelines and fail to trust one's inclination about what seems to be the right thing to do. You are the expert in the situation. Usually, you have gathered information. Guidelines are very general, are very broad, and usually when you mixed, like, guidelines are usually like some kind of Frankenstein's monster of literature. Sometimes they're made really good, sometimes they're not. But all of, like, from cutting the literature in different ways and adding it into guidelines that might be biased by conflict of interest and so on. One of my main problems with guidelines, and I've made a video about this as well. And if you want to know more, check out John Ioannidis, Jerome Hoffman, YouTube videos about guidelines, First 10 EMs, rants about guidelines, and so on. What are the problems with a lot of these guidelines is that they don't include the inclusion criteria from the studies. So you don't know when to apply the guidelines. It doesn't say in the top of most guidelines, well, use this guideline for this particular patient in this particular scenario, like chest pain patient in the emergency department of this age group. I know it doesn't have to be that specific, but there needs to be some kind of inclusion criteria and exclusion criteria, and that doesn't always say in the guidelines. The same with clinical decision rules. They usually, like, they're made for a specific purpose on a specific population, and sometimes they are overused in, like, the typical example is the Wells criteria. Wells criteria is sometimes is sometimes used for all purposes. Everyone with a chest needs to go through the Wells criteria and maybe the PERC score before that to rule out pulmonary embolism, and that is not the way it was intended to be used. And you're kind of jumping right to the SPOC, so the system 2 kind of way, and you're jumping over the Mr. Bean, what is the problem, and kind of pattern recognizing as well. You're jumping over that as well. So that is biases that are from system 2, and they are really, really important as well. So yeah, and this is Croskerry who said this. Okay, so remember these 3 areas that we had in the beginning. The EPC, the error-prone conditions, and then you have your thinking failures, and then you have your knowledge deficit. These are the 3 reasons for diagnostic failure, and now we're going through what we can do about it. So let's say error-prone conditions, and I promised you a list here, and this is from the cognitive autopsy from the 42 cases. These are the most common error-prone conditions, but there are lots more. But fatigue and handover error and sleep deprivation and distractions like slips, high-stress situations where you are cognitively loaded and time-pressured, and maybe you have Rakido where you have crowding and corridor consultations and so on. These are like daily things in the emergency department, and as time goes on, we get more and more decision fatigued through the day and through the night. And so these are the error-producing conditions, which makes us use what Croskerry calls the cognitive miser function, where you stop using your surveillance systems it becomes overloaded or it becomes tired, and you just go with decisions that you probably would go to, like, would use system 2 on. You'll just use system 1, and you'll be more prone to error. So the cognitive miser function is a central piece of the reason why these EPCs are a problem. All right, so what can we do? Well, to avoid this cognitive miser function, or at least reduce it, well, we could talk about the crowding problem. That's a problem that these are complex problems, and there's not just one solution to all of them. The crowding problem with the exit block problem, with all of the intricacies about that is something that we should talk about. We could talk about, sorry, this is Danish, but work environment, like Arbejdsmiljø, are we getting good shift patterns? Are we working too often as emergency physicians? Are we getting enough rest? Are we getting enough, so on and so forth? Then you have this distraction culture. Oh, could you look at this ECG? Could you look at this ECG? Could you just you are constantly exposed to slips, as it's called in literature, where even the best expert, even the adaptive expert, will miss things if they are in a train of thought, and they get distracted because someone is interrupting them. So interruptions are, I think Scott Weingart has made a great post about this, like decision fatigue and slips, and there's like the error rate is through the roof when we do this too much. So it's really important that we create a culture and a work design a emergency department where distractions are minimized. Okay, and then there's you can standardize certain things. You have a protocol of how you do handovers, or maybe don't do handovers when you're the most tired. Maybe you should do handovers an hour before actually going home. Or you can do SBAR, or there are different ways of doing this. I mean, all these things are so important, and they're intricate and they're complex, and but it shows one of my main points about when we are talking about EPCs, that the doctors, like the the quality of life of the doctor is a patient safety issue. If you want to make it good for patients, we need to make it good for all health personnel, doctors, nurses, everyone who's in this service of ours. We need to focus on these things, because if we don't, then a lot of these conditions, we will go into the cognitive miser function, will slip, and we'll make mistakes. I think this thing is a good way of thinking about when we implement new things. We should use what you might call the oiled left hand method. So when you're testing objects, like for usage, like you made a new scissor. Well, this scissor is great with your right hand when you're awake, and you can cut paper in all kinds of styles and so on and so forth. Well, how does it work? You need to test it for the right environment, and we are not at our best and brightest all the time in the emergency department. Everybody knows that. It's hard to find a time when we actually are. And so you need to implement stuff that you want to implement in the emergency department. You need to test with the oil left hand method. So if you test with scissor if you oil it up with like vegetable oil, and you try to use the left hand instead of your right hand if you're right hand dominant, then try to do the same tasks with the same scissor, and you'll encounter problems, and you will have to redesign that scissor so that you can use those. So that you can become better at even in difficult scenarios using that scissor. And that's the mindset that we should actually use, I think, for fixing problems in the emergency department. We need to take the doctor who just came off shift. You need to pay him or her for staying an hour more, and then you have to test whatever you want to test on that guy or that girl, because then you will see some of the flaws that you might not have thought of. We also need to do what you call pre-mortem, what Gary Klein calls the pre-mortem. It's a concept where you have to, before anything gets implemented, you sit around a table and someone orchestras the people sitting around the table to say, well, this plan failed that we were going to implement. That's why it's pre-mortem. And now you have to give me write on a list in 3 minutes why it failed. And then you write it on the list, and then you write it up on the board, and then you have 3 minutes to what are the solutions to these things on the board. And then so there are YouTube videos going through this, and this probably is a good process to kind of get out of the way the obvious things that might be a problem in when implementing new stuff. So that's just some of my thoughts about EPCs. Knowledge failures, I mean, there's lots of ways that we could improve the way we present information and materials for people. It talks to this like the cognitive load theory and so much. I've done a Danish block in 6 parts called Teaching Theories or Læringsteorier in emergency on akutmedicinen.dk, and I've done this video as well going through a lot of the stuff that I'm going through in this block, and this is in English, so check that out. And then in the end, towards the end here, you have thinking failures, and how do we actually become better at this. And it's important to say that these thinking failures, usually it can be called debiasing mindware, and a lot of these things, there are 150 different biases. None of them are going to be fixed by one size fits all. That's point one. That's important. This is a complex problem, and it's something that it's not only a problem. Sometimes it's a good thing to have these biases. So it's about balance. You can't be in system 2 all the time. So and some of them are more general. Some of them are more personal. and some of them are highly local, and some of them are more like system-wide implementation. So that's just, I mean, and evidence has arrived about these things in the last couple of years that wasn't there earlier. Like in the beginning, Patrick Croskerry usually says like it's important just to know about these things. It's important just to know about these area of like the biases and become aware of them, and then maybe you can try to design your everyday so that you have habits and cues that you, when these things arrive then or occur, then you will try to go into system 2 and try to compensate for it. But now there more and more evidence amounts to how we might be able to fix some of these things. And one of my favorite things is like the forcing strategies. It's like an oldie but goodie. Some of these forcing strategies are generic. So for instance, forcing strategies are like, it's like more of a habit. Every time you see a certain cue, you will need to go into system 2. It's like, it can like catapult you from system 1 thinking to system 2 thinking by having this habit. So an example could be, okay, you have a patient with abdominal pain, and there is a pain in the right lower quadrant. The patient has not been eating. It's been just under 24 hours since the debut of pain. They're soft febrile. They have a bit of inflammation markers in their blood samples, and they are tender when you touch the area. Okay, so it's really hard not to think about this could be an appendicitis. That's our pattern. That's why that's our illness script that's most people's illness script of appendicitis that I just simplified described. So that will be triggered for us, but we cannot premature close yet, and we need to, a way of forcing us to think differently is, or at least consider other diagnoses is, you can say, well, a hand of God comes down and says, well, now we go like an hour or two into the future, or maybe a day into the future, and this was not the diagnosis. Okay, well, what was it then? That's one way of saying it. That is the it's not that forcing strategy. You can also like, okay, so another way of forcing you to think in system 2 with these cases could be, well, what percentage would you set, like what pretest probability would you put on that diagnosis, appendicitis? Well, maybe 10%, maybe 30%, maybe 50%. No matter what kind of percentage you will set on it, it's probably not 100%. Then there's something wrong with your thinking, or you haven't been in medicine long enough. So let's say you say, well, it's maybe 40 or 50%. It's a really high diagnosis, a high risk diagnosis here, or high risk of this being appendicitis. Well, there's still 40 or 50% chance of this being something else. And for the emergency physician, in those 40 or 50%, you need to be able to distinguish, is there anything else in those 40 and 50% that need to be ruled out before you just go to think appendicitis. Maybe this could be DKA, diabetic ketoacidosis. Maybe this could be, maybe this could be a ovarian torsion presenting atypically and so forth. And then you don't have to work it up. You just have to consider it. And with the data points that you have, consider, have I asked about these things? Have I even considered these things? And should I ask more questions just to make sure about these things? So that's like the forcing strategies. Another, these are generic forcing strategies that can be used always. I also have a lot of, in the EM case episode on this topic, which I referenced in the beginning, you will hear Walter Himmel also have like personal forcing strategies. I think he says something about all diabetics are drug seekers. Like every time you see a drug seeker, he says to himself, a forcing strategy, well, all diabetics are drug seekers. That's more like a forcing strategy towards his maybe affected bias towards drug seekers, that, here they go again and so on. But this makes the switch in his brain so that, well, this is not well, diabetics are also drug seekers. These are human beings. Like that's kind of way, so that kind of neutralize your maybe negative affected bias towards drug seekers. One of my personal forcing strategies is as I told you, when I see someone ceasing, I want to, well, this patient is not ceasing, they're moving in a specific, and I have to convince myself, why is this a seizure? Why is this not a pseudo seizure? Why is this not a syncope? That's one of my, and these forcing strategies, as you become more and more expert, they will become more and more nuanced and more personal. And some of them will borderline on heuristics, like heuristics being every time you see like more rule of thumbs, like every time I personally see one of these, I have to rule out A, B, C, and D. That's a heuristic. Okay. Then you have this huge box, maybe one of the hugest boxes here about how to fix our thinking failures is becoming good at critical thinking, rational thinking. And I've made several videos and several educational material about probabilistic thinking and cases, about how to think probabilistically and Bayesian. And like the concept of things not being dichotomous but being on a spectrum, the concept of a test is not interpretable without you interpreting without you knowing or judging what the pretest probability is so important. The thing about signal noise, that some symptoms are not as easily recognizable as others, but you need to put more value. I mean, this kind of thinking, probabilistic thinking, is so massively important by itself, but also in this context. And kind of probabilistic thinking, when you know probabilistic thinking, you will also kind of, like, maybe at least cognitively you can embrace uncertainty. Emotionally is kind of hard, oftentimes, especially in our culture, but embracing uncertainty is one of the important things that is also like part of rationalistic thinking. And EBM, evidence-based medicine, is also part of that. And there's a long list beyond this, but yeah, rationalistic thinking, like being good at system 2 thinking, is an important thing. Then you can have situational awareness, and you might be able to simulate you might be able to stress inoculate by simulation, by visualization. Like if you're in a heart scenario, when this shit hits the fan, so to speak, then you need to be able to go into the scenario and become much more and much less aroused. You need to the balance between this being a challenge and this being a threat to you needs to balance towards this being a challenge, and so you're not scared of it. And there's a lot of things you can do. You can do visualization exercises, like go through in your head a cardiac arrest. What would you say? Where you would stand? What would you do? And you can check out Lauria and Hicks. Hicks has made an article called Human Factors, and Lauria has made an article called I believe Beat the Stressful, or I can't remember the exact name, but Beat the Stressful, or Breathe, Talk, See, Focus, are some of the cues that you can, or some of the things that you can do in the situation to be able to de-stress yourself. Then you have to do simulation, where you actually stress inoculate yourself, like you vaccinate yourself against these situations so that you can make decisions in these stress situations. And then you won't, in the same way, be affected, and your thinking won't be affected in the same way when you are in these situations. Then economical thinking, and that is an important concept that relates to rational thinking. It's not anything about money. It's about, that in emergency medicine, for instance, in the resource bay, everything is a zero-sum game. There might be 10 things in this guideline that you need to do. My common example is, well, if you have an anaphylactic patient, everyone knows you need to give adrenaline, and then it says some kind of glucocorticoid, and then some kind of antihistamine. And the two last bits, I don't know why they are there. They are not important according to the new guidelines from England, and has in what for what I know, never been really evidence-based at all. And they just and they just take away mind power and and you need to be able to like, and people might say, oh well, but it doesn't hurt to just give it. Well, it does, because you're using mind power, just thinking about, oh, where do I find that, and and using a line for that. And I mean, so that's opportunity cost, that everything you put into a closed scenario like that will cost something, and even the things that might not hurt the patient, like because of the drug is not hurtful, will hurt the scenario, because it takes away energy, it takes away the nurse, it takes away your thinking, so on and so forth. So that's important. That's economical thinking. Another way of thinking about economical thinking is, or priming yourself to think a bit more economically, is, as I've done in my neurological lectures, like when you have a problem, like think of the three most important blood samples. Think of the three most important diagnostic tests that you want. Think of the three most important questions that you want to ask this patient. That's a way of, that's an exercise for trying to become better at not just shotgunning everything, but actually trying to see what is the most important. If I only had three things that I could do, what would I do? That's economical thinking. Okay, we need to also we need to nurture a culture of expertise, as I already talked about. And if you want to know more about that, look at my video about these like expertise things, and also look at my or look at Daniel Kahnemann's book about culture code. We need to adapt certain debiasing strategies, and that could sometimes be smart checklists. Like after you've done with your scenario, then you go to your book, and this, like that's what we do sometimes in EMCC, that we have a checklist compendium where you check how I thought about this. And it's important. You still have to be the one who puts in information. You still have to be the Mr. Bean. You still have to data gather and say that, well, this sounds like this and not that. But then you can use checklists sometimes for checking your thinking and checking that you get everything right. I believe that you also need to optimize your communication skills. I've made a lot of points about this and your entire video about this and lots of blogs about this, so that you are able to gather information, talk to patients, and also treat them with compassionate care meanwhile. And then what Gary Klein and what Scott Weingart and Stank Imlin's Simon Carley talks about, seeing what others don't, and how we kind of practice seeing what others don't, and like how do we notice the cues, like in the patient who's bleeding, who had a trauma, what kind of cues can we notice? Instead of just looking at the monitor, instead of just looking at anything, just go into the room, look at the patient, notice what is off. And if for instance, you might notice they're sweating, they are kind of in this sense of doom. These are cues that this patient is bad, but you might not notice these things if you're not actively trying to do it. So all this is an active process. This is not something that happens passively. It's something that you have to strategize and reflect on when you go through cases. And you try one of the things. Try forcing strategies, just once a day, or try give me 3 just once a day. Try to visualize a hard situation before you go to work, and then check out what you would do. And if you don't know, then check it out and see where that thing is that you need it, and so on. Yeah. I've made and this, just to sum up, this is Croskerry, and he's made a good just summarizing slide or table here from his this arguing piece that he made, where he says, like, okay, so you have intuitive processes and you have analytical processes, system 1, system 2, and it's not just about saying that you don't well, I don't want to do I don't want to do system 1. I just do system 2, and it's he talks about here that how you can mal-adapt or like take this entire lecture the wrong way. Like you shouldn't take away, like you shouldn't say like, oh, I'm just a system 1 guy. I'm ignoring the impact of multiple biases. I'm using the heuristics that I was taught, and I don't want to update my heuristics. I am not slowing down when I should. For instance, when I have a patient who I might have an affective bias towards, and I'm just I'm just the impulsive. This is not the way that we should do it. But it's not either the way that we shouldn't take away from this lecture. Oh, I'll just only be in system 1. Then you'll be paralyzed. Then you're creating paralysis by analysis. You won't be able to dare to make anything or make a decision. You might reason. You might think that you're reasoning for some like, oh, the guideline says this, and but why do this guidelines say that? What was the inclusion criteria and so on? So and you might be using a linear, and we haven't talked about complex and simple systems, but that is an important topic as well that I've covered earlier. But you might be using an algorithm in something that is really complex, like the undifferentiated patient with chest pain. There is no algorithms for that patient. The undifferentiated patient with hypotension, there's no algorithm for that patient. This is a complex system, a complex situation where if you did the same thing all the time, it would go different ways all the time. That is the definition of a complex system. And you need to, like in complex systems, you need to be adaptive. You need to not think linearly. You need to not use algorithms unless you can, like, okay, the hypertensive patients, I have seen that they have hypertension, they have bronchospasm, they have stridor, and they just ate peanut allergies. Okay, you as a doctor has like now taken the complex situation and then put it into a smaller, more simple system, and then saying, now we'll try out my hypothesis in this situation by treating with adrenaline. And if that doesn't work, we'll do it one more time. But if that doesn't work, I have to change my hypothesis. That's the adaptive way of doing complex thinking. And I can use an algorithm once I have done a plan. I can take up my checklist book once I've like hypothesized that this will be anaphylaxis. Then I can use it, but I won't use it before because it's too complex. There's too many variables. There's too many unknowns. There's too many puzzle pieces that we haven't yet known. We don't know whether it fits our puzzle, the puzzle that we want to collect, or not. So this is a hugely important topic that I have covered elsewhere. Okay, and then, of course, having an adequate knowledge. Well, if you don't know, then you just don't know. And these are the things that we should be doing instead. Well, for system 1, making intuition scientific. Yes, creating supportive environments for decision making. Exactly, that was the culture thing. Minimizing conditions that force default to intuitive processing. So that was the EPC. Don't do the miser function. System 1 is good, but it's not good without system 2 surveilling it. So if you because then you don't know when you should surveil something, then you don't react to the cues that maybe I should go into system 2. You don't. So that's why EPCs are so important to check out and to minimize. And then maximize time and practice in specialized workplace settings. You need that experience and deliberate practice, and then you can become from system 2 to system 1 in these things. You can become expert. Okay, and then system 2, learning about the nature of the extent of the prevalence and biases. Yes, that's what we've done here, to a certain extent anyway. Promoting thinking about thinking, that's what I'm doing here as well. And what I've done in the other videos about probabilistic thinking. Carrying out cognitive and affective debiasing, including forcing functions. That's what we just talked about, how we can fix this. Patrick Croskerry talks about a lot of other things. But these are the things that I have used and I think are the most important right now. But check out his resources as well. Promoting critical thinking in general, yes. Promoting vigilance, and the thing is, promoting critical thinking is not just promoting it. We can always say, Well, first of all, what is our definition of critical thinking? We can always, it's like a power word in universities. Oh, we should be thinking critically. And in med school, oh, we are all thinking critically. But just because you come into med school doesn't mean that we are good critical thinkers. I'm not saying that I'm a good critical thinker, but I'm saying that we should, in med school, we should really focus on critical thinking as it applies to our clinical setting, and not just we need an entire new way of thinking about these things in med school. And I don't know if they're doing it right now, but maybe not. But if they're not, then they should. I know we weren't introduced to Bayesian thinking. We weren't introduced to all of these things. We focused on the knowledge, not the how do we apply the knowledge in the same way. Then we should promoting Bayesian reasoning. That's what we're doing in the emergency medicine core competences course as it applies to emergency medicine. Using expert content knowledge, that's important. That's something Gary Klein has talked about called shadowboxing. Shadowboxing is a task that we can where you can like harness, like experts, like adaptive experts are usually pretty bad at saying what they like explaining why they made the decision that they did, but that is something that can be harnessed maybe through Gary Klein's shadowboxing method, where you go through a case with an expert and with novices, and then the novices will commit to their answer about what they think is going on after a certain amount of time, and then the expert will tell them what is going on, tell their answer what's going on, and then they will talk about why they think it's going on, and then the novices learn from the expert that way. That's shadowboxing, and then use interdisciplinary knowledge mapping. Yeah, and I'm not entirely sure what he means about that, but so I'll let you read that anyway. But so we need both of these things. Cognitive biases belongs here, but being expert, we will also reduce these biases. So that's my video about this. Please comment below, and please tell me if there's anything I missed or anything you want to hear about next. And thank you so much for listening in.